Now we have Dr. Nandini Malshe, a dynamic pediatrician who is presently the Associate Professor, Department of Pediatrics, Bharatiya Vidyapeeth University Medical College, Pune. She is very closely associated with Bharati Vidyapeeth since her undergraduate days, as she has done her MBBS, DNB, fellowship in neonatology, and all her posts from residency to the present post with Bharati Vidyapeeth. She holds a DCH degree from CPS, Mumbai. She has an immense teaching experience for the last 11 to 12 years and has been a faculty at many pediatric conferences and a certified trainer in basic patient safety course of the Chinese University of Hong Kong. An active participant in many conferences, national and international level, and a number of research publications to her credit. She has been a principal investigator or a co-investigator for many clinical trials, especially with respect to immunogenicity and reactogenicity of many vaccines. Let's hear her on antenatal counseling, way forward collaboration between obstetricians and pediatricians. Madam Nandini Malshe, please.
Thank you so much for the kind introduction. I thank the Thane Society of Gynecology, IMA, and Dr. Bedekar Hospital for inviting me to give a talk on antenatal counseling, a way forward. Today what we'll be discussing will be the routine cases, like a 30-weeker preterm is going to deliver, what points to be covered in antenatal counseling to the parents, what need things to be stressed on, and ultrasound reports with the patient comes with the antenatal 19 weeks or 20 weeks ultrasound report, what counseling we should be doing on those conditions. So what we'll be discussing will be the whom to refer, when to refer, and what to counsel. So suppose a 32-weeker 1.2 kg has come in preterm, threatened preterm labor. We all know that 32-weeker 1.2 kg is going to require an NICU stay. So what parents routinely ask and what we should counsel them is, since morning we all have heard about antenatal steroids and antenatal magnesium sulfate. So definitely yes, we should be giving antenatal steroids and antenatal magnesium sulfate. What parents need to be told is about the duration of NICU stay. How long this baby is going to be, because that's the first question parents ask. Okay, how long the NICU stay of a baby is going to be. So we need to give a rough estimate about the NICU stay. We have to give a survival data of our own NICU. There is no point giving a survival data of a US for 32-weeker 1.2 kg. But we actually have to give a survival data of our own NICU, how much is the survival rate. We have to give a morbidity data, like what percentage the baby is likely to have an intraventricular hemorrhage, what percentage the baby is likely to have an NEC or sepsis. Of our own NICU data, we need to give it to the parents so that they have a rough idea. A rough cost estimation for a 32-weeker 1.2 kg, what is going to be the rough cost, so that parents are mentally prepared that this much cost is going to be there. And if it is possible, the NICU visit to the parent so that they know what equipments we are using, how we are going taking a good care of a baby, how sister doctors, nurses and patient ratio is being maintained, how asepsis is being maintained, so that they don't ask any further relatives to come and see the baby. So these things need to be informed to the parents before a delivery of a 32-weeker 1.2 kg. Coming to the ultrasound finding reports, and suppose a 19 weeks old gestation, the patient has come with the ultrasound report of a right kidney which is 19 into 10 millimeter and pelvis is no dilatation, and left kidney is 23 into 10 millimeter with AP diameter of 7 millimeter, ureters are not dilated, amniotic fluid volume is adequate. What to do? Continue pregnancy, not to continue pregnancy, terminate pregnancy with this report, it's a dilemma. So when to call it is an antenatal hydronephrosis. If the anterior posterior diameter of a renal pelvis, this is to be taken into consideration to call it as an antenatal hydronephrosis. And if this AP diameter of the renal pelvis is more than 4 millimeter in second trimester and more than 7 millimeter in third trimester, it is to be called as antenatal hydronephrosis. How we remember is AK-47. So 4 millimeter, 7 millimeter diameter. If it is less than this diameter, no hydronephrosis, forget it. But if the diameter is more than 4 millimeter in the second trimester and more than 7 millimeter in the third trimester, it's hydronephrosis. We need to look out for further things. So this is how the anterior posterior diameter is measured. So to classify it as in the second trimester and third trimester as mild, moderate and severe, the various guidelines have been given, and these guidelines are freely available on the net. These are guidelines by Indian Academy of Pediatrics published in 2013, and we still use these guidelines also only. What additional parameters on the renal ultrasound we need to see when there is a hydronephrosis? We need to see whether there is oligohydramnios, means kidneys have already started, there is a obstructive uropathy which is taking place. Dilated thick wall bladder, it tells you that there is obstructive uropathy. Calyceal dilatation, either maybe because of back pressure changes. Ureteral dilatation, maybe because of reflux or primary ureteral dilatation. And perinephric urinoma, means obstructive uropathy. So these things, additional renal parameters need to be looked into the antenatal ultrasound. Plus sonologists keep a watch on a fetal bladder. If fetal bladder is distended in the first ultrasound, they need to see whether fetal bladder is emptying completely or not emptying completely. This is an additional point which need to be considered, because if the fetal bladder is not emptying completely, means it's obstructive uropathy, again it's not a good indicator. Then something called as a loss of renal parenchymal echogenicity, and which is suggested by the cortical thinning, poor corticomedullary differentiation, increased renal echogenicity and renal cyst. Again, they doesn't have a good prognosis. Additional parameters which need to be screened on antenatal ultrasounds are systemic abnormalities like cardiovascular abnormalities, neurological, gastrointestinal, skeletal. As Pradeep and everybody has already discussed, if one system is abnormal, we need to screen for other systems also, whether any abnormal into any other system. So that it increases the risk for the life. And the soft signs which need to be seen are increased nuchal translucency, which increases the risk for genetic abnormalities, echogenic focus in the heart, absent nasal bones, shortened long bones, echogenic bowel, choroid plexus cyst and ventriculomegaly. So these additional signs also to be looked into the renal ultrasound. Termination of pregnancy is not recommended for fetuses with unilateral or bilateral antenatal hydronephrosis except in presence of extrarenal life-threatening abnormality. Coming to the second case, that is choroid plexus cyst, which is a common finding which all of us come across at 90-20 weeks of age, my pregnant mother coming with the ultrasound report of choroid plexus cyst. So what things need to be considered when the counseling has to be done? What factors need to be taken into consideration? Whether it's isolated choroid plexus cyst or multiple choroid plexus cyst, what is the maternal age and what are the serum markers suggestive of? These three things need to be considered while doing a counseling of a choroid plexus cyst. If it is an isolated choroid plexus cyst, no further investigation is required if the maternal age is less than 35 years and if the serum markers are not suggestive of fetal aneuploidy. No further investigation, no further management. But if it is an isolated choroid plexus cyst, but maternal age is more than 35 years old, or if the maternal high serum factors like you do creatine alpha fetoprotein inhibin A, they are suggestive of trisomies, then we need to advise fetal karyotype. So maternal age and maternal serum markers for aneuploidy should be taken into consideration for choroid plexus cyst counseling. If it is a fetal choroid plexus cyst with additional malformation, again karyotyping is to be advised, and with additional soft markers, additional counseling with further ultrasound. So the important thing to remember in the choroid plexus cyst is it's isolated or multiple, where is associated with other anomalies, what is my maternal age and what is the maternal serum risk factors. So these factors need to be considered while doing a counseling. Similar thing, next common thing what we come across is the echogenic intracardiac focus. Routinely this is not very commonly seen around 90 to 20 weeks of gestation, but may be seen around 22 weeks or 23 weeks. It's a good age to pick up the echogenic intracardiac focus. And they are seen like this foci echogenic. They are commonly in the ventricle, but maybe in the atria or maybe multiple echoes. So they should be evaluated as a part of 4-chamber cardiac view at around 19 to 20 weeks, but may be seen around 22 to 23 weeks also. Again, the maternal age, maternal serum markers for aneuploidy and number of foci should be taken into consideration. If it is an isolated intracardiac focus and aneuploidy risk is less than 1 in 600 by the maternal age, that is 35 years, no further investigations are required. If it is isolated intracardiac focus with the aneuploidy risk which is more than 1:500 for the maternal age, that is age more than 35 years, or maternal serum markers are positive, fetal karyotype is to be done. If it is a right-sided, biventricular or multiple or conspicuous, then expert review with fetal karyotype needs to be advised. So in both the conditions like choroid plexus cyst and echogenic cardiac focus, maternal age and serum aneuploidy markers need to be taken into consideration while doing a counseling. Mild ventriculomegaly. The cerebral ventriculomegaly is defined by a cerebral atrial diameter of more than 10 millimeter, and mild is defined as more than 10 to less than 15 is defined as mild. More than 15 but less than 20 goes as moderate, and more than 20 goes as severe ventriculomegaly. The etiology differs. So cerebral ventricles more than 10 millimeter are associated with chromosomal and central nervous system pathology, and expert review needs to be for detailed anatomic evaluation for additional malformation and soft markers. Laboratory evaluation for congenital infections and fetal aneuploidy, because Torch group of infection is commonest association with fetal cerebral ventriculomegaly. And MRI is a potential additional imaging technique which needs to be done. Even if it is a mild ventriculomegaly, we need to tell the parents in the antenatal counseling that we need to see for the neonatal developmental outcomes, because they are known to have delayed development, slightly delayed development. So neonatal assessment and follow-up as a potential for subsequent abnormal development is most important. 24 weeks, small VSD with overriding of aorta, small pulmonary artery, diagnosis is tetralogy of Fallot. Since it is a 24 weeks pregnancy, we really cannot do anything, but prognosis is good if the delivery is done in the higher center. So advice is going to be continuation of pregnancy, but fetal karyotype for the perinatal management, because sometimes they are associated with anomalies. So how aggressive to be during the resuscitation after delivery? For that to decide, a fetal karyotype and 22q FISH microdeletions need to be done even if the pregnancy is at 24 weeks, and delivery should be done at the tertiary care center. Coming to the next, echogenic bowel. So these are the echogenic foci into the bowel. So echogenic bowel is defined as a fetal bowel with homogeneous areas of echogenicity that is equal to or greater than the surrounding bone, and they are associated with the fetal aneuploidy and non-chromosomal abnormalities. And fetal aneuploidy which are commonly associated are 13, 18, 21 and sex chromosome, and non-chromosomal abnormalities such as cystic fibrosis, congenital infection, intraamniotic bleeding, IUGR babies, congenital malformations of the bowel are associated with echogenic bowel. So if they are grade 1 echogenic bowel, no further investigations are required. But if it is grade 2 or grade 3, what we need to do is detailed ultrasound screening for structural abnormalities of soft markers for aneuploidy, detailed evaluation of a fetal abdomen for intestinal obstruction or perforation, detailed evaluation of a placenta for echogenicity, thickness, position and placental cord insertion. Genetic counseling is required since they are associated with aneuploidies, and laboratory investigation like fetal karyotype, Torch group of infections, maternal serum testing like alpha fetoprotein, HCG, DNA testing for cystic fibrosis if that is considered as one of the diagnosis, and testing for congenital infections. So these are the minimum investigations which are required if it is a echogenic bowel of grade 2 and grade 3. 30-weeker diaphragmatic hernia. You all are experts in it management. So continue the pregnancy till term it's possible. What are the antenatal factors which adversely influence the prognosis? One is large size, one is diagnosis less than 24-weeker. But be mind you that even if the diagnosis after 24 weeks, still 25% of the cases are missed. Because if the intestines are into the chest and if there are no peristaltic movements of the intestine, the echogenicity of the lung and the intestine remains the same. So it's very difficult to differentiate between the lung and the intestine. So even after 24 weeks, so 25% of the cases are going to be missed on antenatal ultrasound screening. They measure the small contralateral lung at the 4-chamber view, and that remains the poor prognostic factor, and lung to head ratio of less than 1, again as a poor prognosis. It's actually incompatible with the life. And lung to head ratio of more than 1.4 is actually 190%, 95% survival rates. But the lung to head ratio of less than 1, again it's a poor prognosis. So what should be the timing of delivery? Continue the pregnancy till term, should not be delivered as a preterm. Mode of delivery, cesarean section and vaginal delivery, no differences. You can deliver them vaginally. The prognosis is going to be same as you deliver them with the cesarean section. Antenatal steroids, if you are delivering them at 37 weeks, as we have already discussed, early term gestations, give antenatal steroids. Truncus arteriosus, if diagnosed at 18 weeks of gestation, I think the prognosis is very grim. And we can put it down on paper that the termination of pregnancy can be considered in view of long-term problems in the survival. So that can be mentioned onto the paper. So prognosis is very poor. If diagnosed at 18 weeks, we still have time in hand, so we can. Arnold-Chiari malformation at 16 weeks, it will have antenatal ultrasound findings like lemon sign, ventriculomegaly, compressed cerebellum, spina bifida, meningomyelocele, posterior foci is hypoplastic. Again, the prognosis is very poor. We can still put it down on the paper since the guarded prognosis, termination of pregnancy can be considered in this scenario. So to conclude my talk, the screening ultrasound at 18 to 20 weeks should include the 8 markers. the 5 markers which are related to the aneuploidy risk, and 3 markers which are related to the non-chromosomal abnormalities. And 5 markers which are related to the aneuploidy risk are thickened nuchal fold, echogenic bowel, mild ventriculomegaly, echogenic focus in the heart, and choroid plexus cyst. And the 3 markers which are in isolation with non-chromosomal abnormalities are single umbilical artery, enlarged cisterna magna, and pilectasis. So these markers to be looked into. Identification of soft markers for fetal aneuploidy requires correlation with other factors such as history, maternal age, and maternal serum testing, as we have already seen in the choroid plexus state and echogenic cardiac focus. Soft markers identify significant increase in the fetal risk for genetic diseases. So, timely referral for confirmation, counseling, and investigation is required to maximize the management. Thank you.